And today it's my pleasure to tell you that we have a very important session of one lung anesthesia and lung isolation techniques, an update on this. And this will be delivered by Dr. Thomas Koshy, who is a very senior professor at the Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum, Kerala. He has many credits to his credits are there. He has 95 and 96 index publications, books and monographs, 67, orations 5, lectures 199, workshops 30, and research projects. So also he has been the president of IACTA. He is the past registrar of the Indian College of Cardiac Anesthesia, as well as the national secretary and treasurer of IACTA and the past state president of ICA, Kerala, and he's also got an FRCP Edinburgh. So he has many feathers to his cap, and we are very glad, Dr. Thomas Koshy, welcome you to the ICA webinar. Thank you very much, and you could please start.
Thank you, Madam, for that kind and wonderful introduction. This is an important update what I am going to present, and the topic was given to me by Dr. B. Radhakrishnan. The topic is written there. One lung anesthesia, lung isolation techniques, updates. What has happened in this one lung anesthetic technique and isolation technique in the last 4 years? So that means I'll be covering from 2021 to 2024. So I welcome all the people who are listening to this lecture. Good evening to all. It will be around roughly around 30 minutes presentation. You can hear me well? All of you are able to hear me well?
Yes, yes.
Okay.
Yes, perfect.
Oh, okay. Now, going to the I'm not covering A to Z of this topic. I have selected certain aspects of this talk and this topic to highlight the updates. So coming to the pre-thoracotomy respiratory assessment, all of us know that it is assessed under 3 headings. One is the respiratory mechanical function, second is the lung parenchymal function, and third is the cardiopulmonary reserve. What is written there is under respiratory mechanical function, the most reliable and relevant is the predictor postoperative FE1. And we know that when the threshold is for risk is more, if it is the value is less than 30 to 40%. I'm not going to calculate this. You must be knowing how to calculate this, or it is written in all textbooks. Regarding lung parenchymal function, the most valid test is predictor postoperative diffusing capacity of CO. Again, the threshold is 30 to 40%. I'll go a little more in detail regarding cardiopulmonary reserve. How you assess the cardiopulmonary reserve in a patient? That is called metabolic equivalent. Short form is METs. The threshold for increased risk is if the patient METs, that oxygen consumption is less than 15 ml per kg per minute. So that is roughly around 4 to 5 minutes. So you and I sitting and listening to this lecture, and I am giving the lecture, we consume around 3.5 ml of oxygen per kg per minute. So that is 1 minute. For the patient to undergo surgery uneventfully, patient should be able to spend at least 4 times or 5 times this oxygen consumption. there it comes the cardiopulmonary exercise testing. So this is considered as the gold standard, CPET. This is an objective assessment. This is not a subjective assessment. Objective, non-invasive assessment of the cardiopulmonary system. This is done at rest as well as during exercise. And you can see this is a treadmill or ergometer where the patient is put through a graded exercise. And you can see that this records ECG, BP, and even ABG can be taken. And it is graded, the work, oxygen consumption, carbon dioxide excretion is with a spirometer attached to the face. And this is the objective testing. See the ECG. If there is an ST segment, arrhythmia, tachycardia, everything will be recorded. This is the objective assessment of cardiopulmonary system. So the patient can achieve a VO2 peak. This is a maximum oxygen consumption of more than 20 mils per kg per minute. That is around 5 mets. He has a very low risk of a perioperative cardiac event. That is VO2 peak, maximum oxygen consumption. If it gives one more measurement, that is anaerobic threshold. When you are exercising in it, usually is aerobic ATP production. As you exercise more, the anaerobic metabolism takes over. So that bridge between the aerobic and anaerobic is, if it is less than 10 mils per kg per minute, again risk is high. And because this machine can record your spirometry, if you are hyperventilating, also there is high risk. So whether this is required in your routine practice, this report came in 2022, which is the best method to assess the functional capacity in patient coming for one lung anesthesia or any major surgery. Which is better, subjective or objective? So this publication, they have reported that they studied 104 patients, came for pulmonary resection. They compared the estimated METs, that is a subjective consultation METs, were compared with the CPET, exercise-based oxygen consumption. What they have concluded that subjective assessment overestimates functional capacity, and they recommend that it should not replace objective testing patients scheduled for lung resection surgery. It's not practical in every patient, but if you have doubt, it is a good idea to subject the patient for a objective test. I am going to review the physiology of one lung ventilation here. I've given 3 scenarios here. This is awake spontaneous patient, a person lying on lateral side. This is the second column is we have intubated the patient and paralyzed the patient and ventilating. And third is the upper or the non-dependent lung has been collapsed. So let us see what happens to PO2 and PCO2. When you lie on your lateral side and spontaneously breathing, this is what is written in red font is the pulmonary blood flow. Pulmonary blood flow is maximum in the dependent lung. And the ventilation is also maximum in the dependent lung. So there is no ventilation perfusion mismatch. And if you give 100% oxygen, the PO2 is in the 500 range. When you intubate, the ventilation switches predominantly to the upper lung, whereas the perfusion remains maximum in the dependent lung. So this produces a ventilation perfusion mismatch, and the PO2 starts dropping to 400 when you give 100% oxygen. And during one lung anesthesia, when surgeon operates, we collapse the upper lung. Then the hypoxic pulmonary vasoconstriction sets in, and that will drive the blood from the non-ventilated lung. So we have collapsed that lung and ventilate on to the ventilated lung. So there is a maximum ventilation, maximum perfusion in the dependent lung. And there is some amount of blood which is remaining in the collapsed lung. That's around 20%. So 50% of the blood will be driven to the ventilated lung by hypoxic pulmonary vascular constriction. So this contributes to the shunt fraction. So PO2 drops to around 100 to 150. This is okay. We need a PO2 around 60 to 70 only. Problem occurs when the non-dependent lung, non-operated lung has a ventilation problem. There are secretion, malposition of the bronchial blocker or a double lumen tube, then the ventilation is in the dependent lung is affected, or there is increased airway pressure here. That will drive blood back to the operated lung. That is not ventilation. So there is a ventilation perfusion mismatch and hypoxia sets in and PO2 drops below 60. So we need hypoxic pulmonary vascular constriction in the operated lung and the collapsed lung. And we don't need that hypoxic pulmonary vascular constriction in the dependent ventilated lung. So this is exactly the pathophysiology of one lung ventilation. This is where we manipulate. If there is hypoxia, we need to oxygenate this 20% of dead space by giving some oxygen, apneic oxidation technique or CPAP to the collapsed lung. And we have to optimize the ventilation and perfusion of the dependent or the anesthetic lung. So there is always a conflict between the surgeon's lung and the anesthetic lung. That is how we manage this scenario. PCO2 remains normal throughout. Now, devices for one lung ventilation. We use both the double lumen tube and bronchial blockers. And there is always a question in our mind, which device is superior, whether I should use double lumen tube or a bronchial blocker. Which one will give a rapid placement, rapid isolation? What is the device malposition rate? Is it different between the bronchial blocker or a double lumen tube? And what about complications produced by the bronchial blocker, or what complication produced by double lumen tube? There are many studies addressing this. Now, the bronchial blockers available in the market, these are the main bronchial blockers which is available in the market and what we are using. So here there is a ARN blocker. There's a wire loop here. And second is the Cohen flexi-tip blocker. There is a wheel mechanism which can be used to bend it towards the right or left main bronchus. And Fuji uniblocker is a fixed bend, so you need to rotate to either side. And this is the EC blocker, a double balloon. You wedge it in the carina, and there are two balloons, and you can inflate either of the balloon for a collapse of the desired lung. Okay, so this is a refresher of bronchial blockers. We have the Cohen blockers. This meant only for adult, 9 French sizes there. ARN blocker, we have got 3 sizes. For pediatric, we use 5 French. Whereas in adult, you can use 7 French and 9 French. Then Fuji uniblocker is available in 2 sizes. And this is the EC blocker, 7 French, that is only meant for adult patient. The balloon shapes are written there. The guidance mechanism I already described. Smallest recommended endotracheal tube is a 9 French for a Cohen blocker. ARN blocker, we can introduce this through even 4.5 endotracheal tube. That means 4.5 means in 2 to 3 months of age of pediatric patients also we can put this blocker. Fuji unit blocker requires a 8 size endotracheal tube, and EC blocker can be put in 7.5. Central channel is there, which can be used for a suctioning, collapse with the operated lung or even to give CPAP. Okay. The ARN blocker requires a little bit or is more challenging and it's interesting to learn. So what I'm going to demonstrate is the ARN blocker size 5 in a child with in our ICU where a patient with the left lung bleed. So we wanted to isolate that left lung. So we decided to put a ARN blocker to the left lung. So this has got a multi-port adapter. So this is myself and he is my colleague, Dr. Unnikrishan. We are putting this. Patient is already intubated. And this is a multi-port adapter. You can see that the blocker is going through this port. This is FOB. This is a size 2.8 FOB from Karl Strauss. And this port is for connecting the circuit for ventilation. And that is a balloon. There is a wire loop tip. Through the wire loop, we will put the FOB and direct the balloon into the desired bronchus. So see here you can see the patient intubated and kept on ventilator. So the FOB cable is connected to the monitor. The whole unit with the FOB with the blocker is connected to the endotracheal tube. And we can continue to, when we are positioned, we can continue, since our technician is connecting the circuit here. And we can continue to ventilate the patient while we are positioning. So this is the control mechanism of the pediatric bronchoscope. And you have the Karl Strauss monitor there. This is a very good one. Going through the endotracheal tube. I'm still inside. And this, you see the carina. This is the. Yeah. Then you introduce, push that under vision. We push that blocker into the desired bronchus. Then we withdraw the FOB to visualize the balloon. It is all round. So this is how we put it. The procedure takes around 5 to 7 minutes. Okay, so how you isolate a child? All of us know how to isolate an adult. A detailed description of this has come in the anesthesia analysis in 2021. So it's better to read this, that illustrated diagrams are there. So one is intraluminal placement, that through the endotracheal tube, you place the blocker, and through the endotracheal tube, you say FOB to correctly position. This is a multi-port adapter I have just demonstrated. There is another method also. You can place this outside the endotracheal tube and check the position by introducing a pediatric FOB through the endotracheal tube. This is how it is put. You can read that. It's not difficult. First it is bent. Then you do the laryngoscopy and introduce the blocker into the vocal cord, push it down. Then you intubate and put an FOB through the endotracheal tube and correctly position it. That is one technique, that is extraluminal. Or you can intral to extraluminal placement. So first you put a endotracheal tube, put FOB through that and position the endotracheal tube in the desired bronchus. Then put the blocker through that, and this tube is split like that. Then withdraw the tube and remove the tube. And again intubate with a single lumen tube and do FOB through that. So a learning curve is there, but it is very interesting to do this in a child and not difficult. Surgeons request many times when there is a surgery for the vascular system or the lung or the mediastinum. Now, this is an EC blocker. Just I said that there are two balloons. And it can be introduced, and this is what is there. And one can inflate the operated lung. So there are reports in the literature, which one is better, EC blocker or a double lumen tube. So this has come in Journal of Cardiovascular Anesthesia in 2021. They studied blocker versus the left-sided double lumen tube in 163 patients. Number of times reposition were required per hour of surgery, degree of isolation, and the postoperative complication like dysphagia was compared between the double lumen tube and EC blocker. The study concluded that for procedures on the right side, EC blocker is less positionally stable than the double lumen tube. There is no statistical difference in repositioning rate between the blocker, EC blocker, and the double lumen tube in left-sided cases, but dysphagia was less with the blockers. This is consistently, all studies have shown that blockers have less complication compared to double lumen tube. This is another study which came in 2022 in BMC Anesthesiology. What they have done is they compared the double lumen tube versus bronchial blocker for video-assisted thoracoscopic surgery. And this study is a meta-analysis of 5 randomized controlled trials. The primary outcome measured was quality of lung isolation, incidence of malposition. Again, the complications were studied, such as the incidence of dysphagia. The study concluded that there is no statistically significant difference between the blocker and the double lumen tube, but the incidence of dysphagia was higher in the double lumen tube group. Now, all of us have a concern that in obesity, what we should choose. Putting a single lumen in obesity is also difficult. So people think that, or people believe that it is better to place a bronchial blocker in an obese patient coming for a thoracic surgery. Let us see what the literature has to say about it. This study came in Journal of Clinical Anesthesia 2 years back. What they have analyzed, the retrospective analysis of 1,500 patients with more than one attempt for double lumen tube. Out of 1,500 patients, around 1,000 had a BMI less than 30 kilogram per m square, but around 400 was having body weight of more than 30 kg per m square. The study found out that with every increase in BMI of 5 kilogram per m square, the difficulty in intubation increased slightly only. See the odds ratio, 1.06 only. So there is no significant increase in the difficulty of intubation with the double lumen tube. So the increase was not clinically significant. So if the surgeon requests that he requires a double lumen tube, or there is significant secretion from the operated lung, pus is there, infected material is there, bleeding is there, so you need a good suctioning. Even if in an obese patient, one can go for double lumen tube instead of bronchial blocker. Now, a new double lumen tube is available in the market. Instead of PVC, this is made of silicone. This study came last year, comparing the silicone double lumen tube with our conventional PVC double lumen tube. And the study was to assess the ease of rail loading over FOB. The branch studied was Shiley DLT and human broncho, which is the silicone one. they have assigned 2 groups of 23 in each group. The tubes studied were 35 and 37 and concluded that intubation with silicone WM tube is easier and faster. That is, you see it's only 7 seconds earlier, which is not significant. But what is significant for us, what is important for us is there is less blood staining with the silicone WM tube. That is 2 versus 60. So definitely one can think about switching out to silicone, and it must be expensive, I perceive. Now, another one which is available in the market is the Ambu Vivacite. That is a video WM tube. There is a video camera at the tip of the tracheal lumen, and that will give a continuous display of when you're intubating with the WM. This is connected to the monitor there. And this is how it is introduced with the laryngoscope. As you go in, you can watch this. There is no need for FOB. So the bronchial cuff goes in, counterclockwise rotation to 90 degree for a left-sided WM tube. Then I introduce further, and you can see in the monitor. And it will reach the carina there. And the position, the bronchial cuff is positioned just 5 millimeter to 10 millimeter distance to the carina. Now, the question is whether it's worth spending money for this video equipped WM tube. So there is a study which has come in the Journal of Thoracic Disease in 2022. They conducted a randomized control trial to compare Robertshaw WM tube in 71 patients. So this is made by Ambu Vivacite 2. What they observed is it has got a shorter intubation time, 44 seconds versus 125 seconds. Relatively easier and decreased need for FOB. The constant visualization of the airway during the procedure allows to correct or prevent malposition quickly. But there was no statistical difference in the lung isolation or incidence of traumatic air injury. We go to the next slide. Now, coming to the anesthetic technique. Incidence of postoperative pulmonary complications with the bronchial blockers versus WM tube. So this study came in 2022. What they found out that they studied in thoracic surgery for lung cancer, less with complications were less with the bronchial blockers compared to WM tube. So complication like that, infection, aspiration pneumonitis, respiratory failure, pneumothorax, and atelectasis were less with the bronchial blockers. The percentage is written there. Now, another update on one lung anesthesia is whether we can use ultrasound to assess the position of lung isolation. This is a double-blinded randomized control trial. DLT confirmation or adjustment, they compare bronchoscopy with ultrasound. So when you use ultrasound, you can look for the lung sliding sign. What they observed was there is no significant difference in the number of patients who achieved sufficient lung collapse between ultrasound group and FOB group. But the time needed was significantly less in the ultrasound group. So this is worth good technique to learn. Another gadgets which has come in the market is the using trackway video stillet instead of FOB for WM tube placement. So this is the trackways stillet, which is a video camera equipped, and that is connected to the monitor. That is introduced into the tracheal lumen and positioned there. This study came in 2022. Just 1 second. I am in a meeting, I'll call it. That is, the study compared trackway versus conventional introduction double lumen tube, then compared with the FOB placement. So 36 patients randomized to 3 groups. All patients underwent DLT insertion under video laryngoscope. And this is the main finding. The time from when the vocal cord were first seen to the DLT properly positioned was shortest in the trackway group. That is around 48 seconds compared to FOB group. And the maximum time was in the conventional group. So again, this is equipment worth purchasing and practicing. One of the recent introduction to the market has come from China. It came in published in 2022. This is the regular Y connector. We connect the double lumen tube, the double connector. Then we clamp one lumen, auscultate for the absence of breath sound on the ipsilateral lung, presence of breath sound on the opposite lung. Then you transfer the clamp from one side to other side. Again, repeat the procedure. So this Chinese company has come out with a Y connector. See, there is no clamping and unclamping. You have to just rotate this. And they studied 60 patients randomized to Y rotatable connector and regular Y connector. What they have found out that it is beneficial to maintain the stability of anesthetic depth, because when you clamp and unclamp and release, anesthetic depth comes down, and this Y rotatable connector shortens the positioning time. Coming to the practice of one lung anesthesia, this is a study which came 2 years. What is the tidal volume one should use? Can we use a very low tidal volume convert? And how is it compared to conventional tidal volume? So low tidal volume means it is 5.6 ml per kg compared to 8 ml per kg. That is a control group. Don't use 10 ml per kg. That is no longer recommended. So this is a meta-analysis of 80 studies. There is no significant difference between low and conventional tidal volume terms of PaO2, PF ratio. That is PaO2 and FaO2 ratio, compliance, hospital length of stay, or mortality. But they have found out that low tidal volume, that is around 5.6 ml per kg, was associated with a significantly lower incidence of postoperative pulmonary complications. The odds ratio is 0.4. So this is an interesting finding. So one can increase the respiratory rate to maintain the PCO2 around 50 millimeters of mercury. Now coming to the pulmonary drug delivery, what is the impact of nebulizers? One can use a pulmonary vasodilator to dilate the pulmonary vasculature in the dependent lung to improve the blood flow to the ventilated lung and reduce the blood flow to the collapsed lung. So 90 patients were randomized to 3 groups during one lung ventilation. Group A received 60% FaO2 with a prostaglandin E1 infusion at 0.1. Group B and C had a 40% FaO2 with an increase of prostaglandin infusion at 0.2. The outcome measures were oxygenation of pulmonary shunt, oxidative stress by measuring the interleukin and malondialdehyde. What the study found out was the B and C had a lower oxygenation, that is SpO2 was anyway more than 95%, not 9900. Lower mean arterial pressure and lower pulmonary shunt in group A, but with less oxidative stress. So conclusion was we should not use 100% oxygen by now. One lung ventilation, because oxygen is also a toxin. So FiO2 could be reduced to 60 to 40% to maintain oxygenation with the prostaglandin infusion. Now, another, I come to the last parts of my presentation. Which one to use, sevoflurane versus propofol in the inflammatory response during lung resection? This is a meta-analysis of 8 randomized control trials. And they studied around 500 lung resection patients. They measured the inflammatory markers in the blood to see the systemic inflammatory response, and also studied in the bronchoalveolar lavage to find out the local inflammatory response. What they have found out that, what the study found out that no significant difference in systemic inflammatory markers between the use of propofol and sevoflurane, but sevoflurane was associated with a minor reduction of interleukin-6. The bronchoalveolar lavage of both the lungs, indicating a decline in local alveolar inflammatory response. So sevoflurane is a safer option, but don't use sevoflurane more than 1 mg when there you have some other problem. Coming to the last part, last 2 slides. How do you isolate if you got this scenario? See, there is a tracheal bronchus. This is a trachea. This is a tracheal bronchus. And you need to isolate. Surgeon request for surgery on the this lung or a right upper lung, right lower lung, or left lung. So different options there. One can use a smaller double lumen tube and push the bronchial lumen to the left side, or it can put a bronchial blockers on either side, or a Fogarty here, or a univent blocker here. Position the cuff here and push the univent blocker to one side, or position the univent cuff across the tracheal bronchus. So tracheal bronchus is not uncommon. And this is a tracheal bronchus of a 6 months, 5 kg patient with a double outlet right ventricle, which we have operated. I'm doing the FOB. The patient had a difficulty in coming on bypass. This is a carina. And you can see the compression of the left main bronchus. External compression. So I push that 2.8 FOB to the left side through this compressed bronchus, left main bronchus, to see anything there distally in the left lung. Okay, all the segmental bronchi are patent. I withdrew the bronchoscope to see the right main bronchus, and here we have the right intermediate bronchus and right upper lobe bronchus, and there is an additional tracheal bronchus here. So that endotracheal tube we positioned above this, so that this bronchus is ventilated. So the skill of FOB is mandatory for anesthesiologists, and there is a learning curve, but it is challenging, but it is rewarding. And thank you very much for your patient listening. Listened to me for the last 35 minutes. Can ask any questions. Hello.
Yes, sir, you are audible, sir.
I can unshare.
Yes, sir. Now you can answer, sir.
That was an excellent presentation and overview of updated information on lung ventilation. Most recent data and studies have been covered very well. Thank you very much for that nice presentation. Momita, do you have any questions?
Sir, till now we have. I didn't receive any questions, sir. I'm checking, sir, if I receive
Hello.
any questions.
Yes. Yes, anybody wants to say anything or are
Yeah,
there any
Murali.
questions? Yes.
Yeah, I'm sorry I was not able to join. I'm sorry, Koshy, I was not able to join the beginning. The I failed with them. And your talk was appreciated. Thank you very much for being with us and giving this very explanatory talk, which is not being done at most of the places in India. Thank you.
Thank you. Any questions? Anybody has any clarifications to provide?
I didn't see any questions on the chat, but
Thank
I would
Well,
just
Clarence
like,
will look into the
I would like
Yeah,
to
I
just
don't have any questions, sir.
anything
I
in
think
the
Dr. Kanchi, is that
yes,
Dr. Kanchi?
yes, absolutely, it's me.
Murli Bolo, he wants to say something, Abjit.
Yes, I just wanted to comment that the lecturer's updated one with updated information. I just wanted to say that in minimally invasive cardiac surgery, we always use one lung ventilation. And
That's
we
right.
preferentially use bronchial blocker on the side and the need to collapse the lung. And we have had excellent results even for robotic cardiac surgery. We use one lung ventilation. And in most important thing which I would like to point out is that in pulmonary endarterectomy, about 2% of the patients develop intrapulmonary bleed. And it becomes very vital to isolate the lung from which the bleeding is occurring. It happens only in 2%, but when it happens, it can be devastating. So what we are doing nowadays, the recommended practice is to put a fiber optic bronchoscope and put a blocker after the event occurs. But what we are doing is we are putting a EZ blocker even before start of the surgery. Once the patient is intubated, we put a EZ blocker and keep it stationed in the carina with one of the balloons in one right and the other one on the left side. And in case there's a bleeding, we already have easy access to secure that. We inflate the cuff on the side where it is bleeding and then sort it out at a very calm and easy manner. That's what we have been doing, and we would like to continue to do this. And the incidence of, as I said, incidence of bleeding during pulmonary endarterectomy is very low, but if it occurs, it has a very high mortality. We need to go on to VV ECMO or VA ECMO with its associated complications. We have to isolate the lung first of all, and then if it doesn't work, you have to go on VV or VA ECMO and wait for the bleeding to stop. So this practice we have been doing that. I just wanted to point out. Thank you so much.
Thank you, Muralidhar, for that update. Good number of centers, including our center, has switched over to EC blockers in adult patient.
Yeah, EZ blockers, they work well and relatively easy to manage.
And some tips for putting the EC blocker is one has to position the tip of the endotracheal tube 3 to 4 centimeters away from the carina. That
Absolutely.
that is
Absolutely.
one.
Absolutely.
When we have a difficulty in introducing, sometimes both these balloons will go to one side. So we can partially inflate and try to push in. But the best method is you introduce and chase it with the FOB. And notice the color. There is a blue cuff and a yellow cuff, and the pilot balloon is also similarly colored. The only
Yes.
disadvantage is the cost of it. The W-lumen tube cost around 2.5 for 3,000. This will cost around 10,000. But one can reuse.
We are reusing up to 10 times. And it works well.
Reuse. So these are the plus or pro and con of a EC blocker. But for a beginner, this blocker is easy to learn. Unblocker is slightly more difficult to learn, especially in pediatrics.
Yeah, unblock is technically challenging. This is relatively easy. Thank you so much for that excellent talk.
Thank you.
Thank you.
Thank you so much.
Any other comments? Anybody who wants to contribute?
I have no idea. We
Ah, Krishnan, your network, your connectivity is poor, Dr. Radhakrishnan.
Hello.
If there are no
Yeah, there will be.
comments, contribution, no questions, I think we can wind up.
I would like to thank Dr. Thomas Koshy for that excellent talk on behalf of the ICA and the ICA academics. And we would like to have you again for some other topic soon.
Okay.
Thank you so much.
Okay, thank you, sir.
Thank you.
Thank you.
Good to see you.
Thank-
I didn't see
Yeah,
your face.
he-
Happy to see
yes,
you. I recognize you from your voice immediately.
you
Yeah,
and good night.
Koshy, there is-
Okay, sir is in Delhi, I think.
Yeah. That's correct.
We can't make out what you're saying.
There is
I
a
can talk.
network issue from BRK, sir.
My system is not accepting image.
Okay,
My
okay.
system today me accepting my. So don't worry. He is yes, excellent. Cardiac.
Radhakrishnan sir, I think
I think it's not
we are
clear,
not
sir.
able to hear what you're
Not
saying.
able to, yeah, hear.
And we can't make out what you're saying.
Don't
Thank you very much. See you again.
Thank you. Thank you so very much
Thank
to
you.
everyone.
Thank you,
you
Koshy
all.
sir.
Thank you.
Thank you.
I can leave.
Yes,
Yes,
sir.
sir.
I think we can sign off here. Have a
Yeah.
very good night, everyone.
Very
night to all.
Good night to all.
Thank you very much.